For decades, the medical establishment has operated on the assumption that coronary artery disease is an inevitable, progressive condition of aging. The standard approach relies heavily on palliative management, administering lifelong pharmacotherapy to suppress symptoms and delay eventual cardiac events. This approach responds to the creeping progression of atherosclerosis. Atherosclerosis is the buildup of fats, cholesterol, and other substances in and on the artery walls. Long before a patient experiences clinical symptoms, these lipid-rich plaques slowly bulge inward, physically narrowing the vascular channel in absolute silence. Yet, longitudinal clinical data contradicts the assumption that this progression is inevitable. Empirical evidence demonstrates that the active state of coronary artery disease is definitively curable through intensive lifestyle interventions, requiring zero pharmacological suppression. This creates an immediate friction within cardiovascular medicine. If the data proves an active biological cure is possible, clinical guidelines still overwhelmingly treat the disease as chronic, progressive, and unyielding. The medical community's failure to recognize this cure stems from an inability to distinguish between the act of halting an active biological process and the entirely separate task of fixing the permanent structural damage that the process leaves behind. To resolve this friction, we must apply a rigorous taxonomic evaluation to disease resolution. We have to separate the status of the pathological process from the physical status of the affected organ's architecture. This table categorizes definitions in chronic disease management. In palliative or remission states, the root cause persists, requiring continuous monitoring. A cure mandates total eradication of the root cause, restoring homeostasis. Reversal distinctly requires the physical regression of anatomical blockages. We have mastered how to completely cure the active biology of atherosclerosis. We continue to struggle to reverse its anatomical scars. The biological mechanics of this distinction are visible in the dermatological parallel of severe acne vulgaris. The active state of acne is an inflammatory cascade driven by sebum overproduction, bacterial proliferation, and hyperkeratinization. Hyperkeratinization is the abnormal thickening of the outer layer of the skin, which traps debris inside the pore. When a pilosebaceous unit aggressively ruptures, the intense, localized biological inflammation actively destroys the surrounding microscopic tissue architecture. Clinicians treat this active disease with systemic retinoids or antibiotics. By neutralizing the bacterial triggers, the active disease is definitively cured, resulting in a total cessation of new inflammatory lesions. Despite the absolute cure of the active disease, the patient is frequently left with permanent atrophic or hypertrophic scars. This split-screen comparison shows the aftermath of the cure. These scars represent a net loss or aberrant gain of collagen. This permanent alteration of the skin's topography is an anatomical legacy, not an active disease. This precise biological dynamic maps directly onto the cardiovascular system. Instead of bacteria driving the inflammation, the trigger is oxidized LDL. LDL, or low-density lipoprotein, is the primary cholesterol vehicle that accumulates and oxidizes within the blood vessel walls. Curing the active inflammation of atherosclerosis stops the progression of the disease instantly. The lipid-driven process halts. The vascular scars, however, remain. These are the fixed calcified plaques permanently embedded in the vessel wall long after the active inflammation is gone. Just as a patient can be cured of acne but heavily scarred, a cardiovascular patient can make themselves biologically heart attack proof, yet still harbor the severe structural scars of their past lifestyle. The landmark longitudinal data proving the existence of this cardiovascular cure begins with the Ornish lifestyle heart trial. Dr. Ornish demonstrated that intensive lifestyle interventions led to a measurable regression of stenoses in 82% of patients. Stenoses are abnormal narrowings of the blood vessels. This experimental group also saw a 2.5 times reduction in cardiac events compared to the control group. At the Cleveland Clinic, Dr. Caldwell Esselstyn's research isolated the specific variables of this cure, focusing entirely on the absolute primacy of nutrition.
The Esselstyn protocol mandates the strict removal of all animal products and all added oils from the diet. The physiological goal is to halt new plaque formation and rapidly restore endothelial function. This diagram shows the first biochemical shift of the cure. A healthy endothelium releases a surge of nitric oxide, or NO. NO is a powerful vasodilator molecule that relaxes blood vessels and actively prevents white blood cells and platelets from sticking to the vascular walls. The second major biochemical shift is the elimination of TMAO. TMAO, or trimethylamine N oxide, is a highly potent vascular toxin linked directly to heart attacks. This is where it originates. Omnivorous bacterial flora in the gut metabolize carnitine and choline, found in meat, eggs, and dairy, converting them into TMAO, which enters the bloodstream. Strict plant-based diets physically eradicate the specific strains of gut bacteria required to produce TMAO. This removes the trigger entirely. By restoring nitric oxide and starving the body of TMAO, these targeted interventions neutralize the inflammatory triggers. The active disease process is biologically cured. This brings us to the core clinical inquiry. If the active disease is definitively cured, why do the arteries remain narrowed and blocked? As atherosclerotic plaques mature, they undergo intimal calcification. Intimal calcification is a regulated, cell-mediated process where calcium deposits aggressively harden the innermost layer of the artery wall, mirroring the exact biological mechanisms of bone formation. The vascular smooth muscle cell aggressively mutates into a rigid, osteoblast-like cell, locking the tissue into a permanently hardened state. Research out of the Icahn School of Medicine at Mount Sinai demonstrates the severe biological resistance of these advanced plaques. Early lipid-rich plaques are reversible, governed largely by the PPARG gene network, which allows plaques to shrink. However, in advanced plaques, PPARG deactivates. It's replaced by the MLL5 and SRSF10 networks. These genes control structural fixation, locking heavily calcified plaques into an irreversible state. A similar recalcitrance is found in myocardial scarring. If a patient has suffered a previous infarction, an area of tissue death caused by a lack of oxygen, the damaged heart muscle is replaced by non-contractile fibrous tissue that cannot be regenerated. This remaining structural damage constitutes a patient's residual risk. Residual risk is the ongoing baseline threat of chronic ischemia and heart failure, driven purely by fixed arterial stiffness and old physical scars, long after the underlying inflammation is gone. We can rapidly cure the fluid biological environment of inflammation, but we are largely powerless to reverse the fixed, calcified architecture of the resulting scar. The standard medical model is misaligned with this biology. It waits for the irreversible structural scar to form before taking aggressive action. Dr. Kim Williams, former president of the American College of Cardiology, has championed a complete pivot toward lifestyle medicine. Dr. Williams argues for the abandonment of event-driven cardiology, a system built around waiting for the heart attack to occur, in favor of prevent-driven cardiology. Executing this cure requires a holistic approach. Exercise increases the production of endothelial progenitor cells. These are circulating stem cells that actively repair microscars on the vessel walls. Meanwhile, stress reduction biochemically lengthens telomeres. Telomeres are the protective caps on the ends of our chromosomes that dictate cellular aging. Returning to our taxonomic table, the data confirms that coronary artery disease is a curable condition. This timeline spans from early physiological triggers to final anatomical scars. Current cardiology is weighted heavily toward the end, deploying stents to manage permanent scarring. The shift requires moving intervention entirely left, attacking the early inflammation. Clinicians must manage expectations. The biologically cured patient must understand that they may permanently carry the calcified legacy of their past diet and lifestyle. Because the structural damage of atherosclerosis resists reversal, success hinges on deploying the biological cure before the anatomical scars are ever formed.